speaking about leaky windows. I'm going to be talking about leaky valves. And I know it's right after lunch, and some of you may be inclined to snooze. Well, I'm requesting that you refrain from snoring. It would be distracting, and it might be kind of embarrassing as well. Okay, so the first thing we're going to talk about is aortic regurgitation. The aortic regurgitation is a common problem. It's reported in 5 to 10% of the population, and it increases with age, and it's more common in men. Patients with severe aortic regurgitation can remain asymptomatic for several years, if maybe even longer, 5 to 10 years. But eventually, once they become symptomatic, there's really no treatment except valve replacement. Here are some of the etiologies of aortic regurgitation. Of course, you have to think about it, is it a valve problem or is it an aortic root problem? And actually, the aortic root problem is the more common reason for having significant aortic regurgitation. Some of these other things are not so common. For instance, rheumatic heart disease, we don't see so much. Systemic other diseases can cause aortic regurgitation, but again, not that common. Again, the dilatation of the aortic root is the most common reason why people develop severe aortic regurgitation. Here's an example. This happens to be a bicuspid aortic valve. Oh, they can't hear me right there? Okay. Here, and you can see that the ascending aorta is significantly dilated. It's approximately 6 centimeters here, where the descending aorta is of normal caliber. You can imagine how the stretch on this ascending aorta puts pressure on the aortic valve so that it no longer can close appropriately, and therefore it's no longer coaps appropriately, and the volume goes back into the left ventricle. So initially, as the valve becomes more insufficient, the left ventricle can no longer compensate. It begins to dilate, and eventually the ejection fraction begins to drop. It is in this region where you want to talk about aortic valve replacement, when you start evaluating for dilatation and ejection fraction drop. Here in the irreversible left ventricular dysfunction, the cat's out of the bag. It's already too late to consider valve surgery. As far as the clinical exam, the classic finding is a wide pulse pressure. You also have apical impulse is hyperdynamic. It's displaced due to left ventricular enlargement. Normal S1 with a loud S2 with a dilated aortic root, a soft S2 with a thickened aortic leaflets. There are 3 murmurs associated with aortic regurgitation. The classic one is a diastolic murmur at the left sternal border if the aortic regurgitation is related to a problem with the aortic valve. It's at the right sternal border if it's a problem with the aortic root. The murmur increases with squatting or isometric exercise. It decreases with maneuvers that decrease the blood pressure. There can also be a systolic murmur due to increased stroke volume, and there is also a second low-pitched diastolic murmur that has been described. It's called an Austin-Flint murmur, and it's believed due to the mitral valve closing prematurely from the aortic regurgitation jet. As far as symptoms, shortness of breath is classic, with exertion initially and then at rest. Palpitations, sinus tachycardia, PACs, PVCs, syncope, and angina can occur. As far as monitoring, echo is the main diagnostic tool. Echo is used to not only evaluate the severity of the aortic regurgitation, but looks at the left ventricular dimensions, left ventricular volumes, and ejection fraction. If the echo is suboptimal, you can always use radionuclide angiography and or MRI. However, they're certainly a lot more expensive than doing an echocardiogram to follow aortic regurgitation. Here's a chart showing the monitoring of aortic regurgitation once it's been first identified. Mild aortic regurgitation, but the left ventricle is not dilated and the ejection fraction remains normal. It's recommended an echo every 2 to 3 years. Even if they remain asymptomatic, but the aortic regurg has progressed, the LV size is still normal and the LV function is still normal, then yearly. But once they begin to dilate and the ejection fraction begins to fall, then you should be monitoring them more frequently before you decide surgery. It's always tricky if they say that they're asymptomatic to recommend surgery. As far as medical treatment, hypertension should be treated with vasodilators, ARBs, ACE inhibitors. Beta blockers should not be used because of the negative inotropic and chronotropic effect. Here's a complicated slide as far as when to decide on aortic valve surgery, but again, the most important thing is whether they're symptomatic. If they're not symptomatic, then you can follow the ejection fraction, follow the dimensions. If they're symptomatic, it's a class 1 indication to replace the valve. If you're not sure about symptoms, you can always put them on the treadmill and decide, are they truly asymptomatic? How good is their functional capacity to decide when you should replace the valve? If you're convinced that they really are still relatively asymptomatic, then you start looking at the ejection fraction. Once the ejection fraction falls below 50, that would be an indication to proceed with surgery, even if they claim they're asymptomatic. Okay, the next slides are on mitral regurgitation. Moderate to severe mitral regurgitation is one of the most common heart valve lesions. Trivial to mild mitral regurgitation is commonly found incidentally on echocardiography. However, to understand about mitral valve disease, you really have to understand the anatomy. It's not just about the mitral valve leaflets. It's also about the mitral annulus, the subvalvular structures, the chordae tendineae, papillary muscles, and the left ventricular wall. Normal and integrated function of all 4 of these components is required for competency of the mitral valve. An abnormal function of any one of the structures may result in significant mitral regurgitation. The etiologies of mitral regurgitation can be roughly broken down to 2 types, either degenerative or functional. Degenerative is a primary lesion of the mitral valve or the subvalvular apparatus. An example of that is mitral valve prolapse or a ruptured cord. Functional is a lot more complicated. Secondary dysfunction is due to annular or left ventricular dilatation and or left ventricular systolic dysfunction, as seen with dilated cardiomyopathies and or coronary artery disease, especially when the right coronary artery is involved with an inferior myocardial infarction. Understanding these categories is important in the management and outcome of mitral regurgitation and the recommendation whether you would proceed for valve replacement or repair. Here are some of the common etiologies of chronic mitral regurgitation and the different valve structures that are associated with it. So at the very top, you can have ischemic heart disease. The next one is, for example, would be mitral valve prolapse. You can have a dilated cardiomyopathy that's non-ischemic. Rheumatic heart disease is certainly not so common. Hypertrophic obstructive cardiomyopathy, we see that somewhat commonly. You can identify a cleft anterior leaflet of the mitral valve that's a congenital abnormality that easily could have been missed all through childhood and young adulthood. Again, quite rare though. Certain drugs have been associated with significant mitral regurgitation, and radiation has been as well. The symptoms associated with mitral regurgitation you're all aware with of shortness of breath, initially with exertion, and then it can even occur at rest. They can have pulmonary congestion, pulmonary hypertension, and atrial fibrillation. As far as the clinical exam, atrial fibrillation is quite common. The apical impulse is displaced. The classic murmur is a holosystolic murmur or a late systolic murmur, appreciated loudest at the apex with radiation to the axilla. There can be a systolic non-ejection click before the onset of the murmur, especially with mitral valve prolapse. Echo is the primary and essential diagnostic test for the diagnosis and assessment of mitral regurg. Imaging should evaluate the structures of the mitral annulus, the leaflets, the subvalvular structures, and left ventricular function. Echo also supplies the associated sequela of mitral regurgitation, which is pulmonary hypertension, tricuspid valve regurgitation, left atrial dilatation, left ventricular dilatation, and systolic dysfunction. TEE, or transesophageal echocardiography, can also be done to further delineate the cause of the mitral regurgitation, or when the transthoracic echo doesn't give adequate visualization. This is supposed to be a video. Is it going to play as a video? Maybe? It's not going to play as a video? Okay. Okay, this is the aortic valve. This is the mitral valve. This is an anatomically normal mitral valve. However, the left ventricle is significantly dilated, and because of that, it's tethering the leaflets of the mitral valve so that it cannot coap. It cannot close appropriately, and here on color flow Doppler, you have significant mitral regurgitation. This is a whole different problem than if you had, for instance, mitral valve prolapse or a very calcified annulus. For those people that are asymptomatic, a stress echo can be helpful in evaluating mitral regurgitation. It can determine the functional capacity as far as how many stages of a Bruce protocol can they walk. If they can only do the first stage, that kind of is a hint that maybe they're not really asymptomatic. 20% or more will have diminished exercise capacity when they tell you that they're asymptomatic or they feel just fine. With stress echo, you can estimate the pulmonary artery systolic pressure with exercise. You can, with severe exercise, pulmonary hypertension as a result of mitral regurgitation is an indication for surgery. Mitral regurgitation severity may increase with exercise and may explain symptoms during exertion, when imaging at rest has shown that the severity of the mitral regurg is less. As far as treatment, again, patients with degenerative mitral regurgitation, their annual mortality is 3% if they have moderate mitral regurgitation and 6% if they have severe mitral regurgitation. However, patients with functional or ischemic mitral regurgitation, they have a worse prognosis. There is no pharmacological therapy that have conclusively been found to reduce the progression of chronic degenerative mitral regurgitation of symptoms and or delay or postponing surgery. So medications are not going to help. ACE inhibitors, diuretics, beta blockers, that are not going to help as far as preventing the degenerative valve from progressing. However, in contrast, degenerative causes of, in contrast, functional causes of mitral regurgitation is different. These people have heart failure. ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, cardiac resynchronization therapy by biventricular pacing, They may improve the systolic function and therefore reduce the mitral regurgitation severity. As far as functional or ischemic mitral regurgitation, surgical repair has not been conclusively shown to improve survival over medical therapy or isolated bypass surgery. So mitral regurg from functional is entirely different than mitral regurg from a degenerative valve problem. As far as management, again, a complex slide. The first thing is, are they symptomatic? If they're not symptomatic, or it's questionable if they're symptomatic, putting them on the treadmill may be helpful. Then you want to look at LV function. Once the ejection fraction falls below 60%, which is generally considered a normal ejection fraction, but it's not normal for mitral regurgitation. They should have higher ejection fractions. That would be an indication to consider mitral valve repair or replacement if not possible. Other things you look at, of course, is the dimensions, but also new onset of atrial fibrillation or significant pulmonary hypertension. In training, I was in training more than 25 years ago, unfortunately. The caveat used to be you fix the valve the day before they go into atrial fibrillation. That's what we were taught. However, you never know when they're going to go into atrial fibrillation. As far as surgical treatment, mitral valve repair is preferred over mitral valve replacement. It reduces the potential complications of a prosthetic valve, especially with a mechanical valve, which requires lifelong Coumadin. Again, the newer anticoagulants you cannot use for mechanical valves. You have to use Coumadin or warfarin. Repair preserves left ventricular systolic function. The ejection fraction may decline with valve replacement. The operative mortality for repair is estimated at 1 to 2%. With replacement, it's in the range of 6%. Of course, there's higher operative mortality with comorbid conditions, older patients, advanced heart failure, mitral valve surgery and CABG at the same time, or other valve surgery, or if there's underlying pulmonary or renal disease. However, mitral valve repair is not perfect. There's recurrent MR after initial successful repair of moderate to severe nature at a rate of about 3% per year. The recurrence is higher with functional or ischemic mitral regurgitation due to progressive LV dysfunction and dilatation from the primary process. The reoperation rate with mitral valve repair is estimated at 7 to 10% at 10 years. Okay, we're going to move on to tricuspid regurgitation. Tricuspid regurgitation is the forgotten valve. And I just recently got a flyer for one of the conferences, national conferences, and I think that was the title of one of the topics, was the forgotten valve, which is tricuspid valve. The most common cause of tricuspid regurgitation is right ventricular dilatation from functional tricuspid regurgitation. Here are some of the causes of tricuspid regurgitation. And again, structural abnormalities of the tricuspid valve are relatively uncommon. The congenital forms generally would be picked up in the pediatric age group. As far as are acquired, again, really quite uncommon except perhaps for endocarditis. As far as symptoms, the symptoms are right heart failure. And on clinical, okay, let's go back, I think. Okay, well, I skipped one, but okay, here's an echo of, again, this is an anatomically normal tricuspid valve. However, the right atrium is severely dilated. The right ventricle is dilated. You can see here in systole that the valve does not close completely, and as a result, you have significant tricuspid regurgitation as demonstrated here in this color flow Doppler. Okay, as far as the clinical exam, right heart failure, hepatomegaly, ascites, lower extremity edema, jugular venous distension with a prominent systolic V wave, a holosystolic murmur, left sternal border increased with inspiration due to increased venous return. As far as medical treatment, diuretics are used to reduce the symptoms and signs of right heart failure. However, aggressive diuresis may further reduce the left ventricular stroke volume and therefore cardiac output. As far as surgical treatment, isolated tricuspid valve surgery is uncommon except perhaps for endocarditis. The vast majority of tricuspid valve surgeries occur in the setting of combined valve disease. Mitral valve surgery with a tricuspid valve repair is considered for functional TR for moderate to severe tricuspid regurgitation. Tricuspid severity may improve with correction of the mitral valve disease alone. However, high percentage of patients undergoing mitral valve repair alone will have progression of the tricuspid regurgitation. So you have fixed the mitral valve, but now, a few years down the road, now they're quite symptomatic from progressive tricuspid regurgitation. So you may have not really done them a great favor. Dilatation of the tricuspid valve annulus at 70 millimeters or more at the time of surgery has been recommended as a threshold to do angioplasty at the time of the mitral valve surgery, regardless of the severity of the TR. And then finally, again, to emphasize, tricuspid regurgitation is not a benign condition. Trace or mild tricuspid regurgitation is found commonly with echocardiography. However, moderate or severe, the outcome at approximately, how did that, okay, let's go back. Okay, however, moderate or severe, at 2 years, the survival rate is only 70% for moderate, and for severe, it's only 50%. So it's actually worse than mitral regurgitation. And that ends my talk. I'll be happy to entertain any questions. Time up, yeah, I did it. Okay, no questions? Yes. Dr. Whiteman.
This is a parallel question. Are there any indications for routine monitoring of, for example, women over the age of 50 for any reason that the insurance would pay for, or if they're only for symptomatic?
Yeah. There's routine monitoring once you've identified that there's significant pathology. Yes, there are guidelines to do yearly echoes or even more frequently depending on the severity. However, unless they're symptomatic or they've already been identified with a significant pathology, no, it is not recommended. Not recommended. Now, if you hear a classic murmur of valvular heart disease of one type or another, that is an indication to recommend an echocardiography, and insurance companies would pay for that.
What about high cholesterol?
Nope, not an indication for doing screening echoes. Yes?
Are there some ethnic groups that experience this type of diseases more often?
No, I can't really say that I would say that I've seen anything where it's specifically a certain ethnic group. I think, yeah.
How many classes, class 1, class 2,
Okay, the American College of Cardiology, the surgical associations, et cetera, they decide on when things are appropriate or not based on good clinical research as well as consensus opinion. And when there's good clinical studies that indicate that everybody agrees that it's appropriate and there's good scientific background, that's a class 1. And then there's a class 2A and a class 2B. Class 2A, the data is not so good, but the consensus is that you should probably proceed. Class 2B is the data is not so good, and the consensus is questionable. There's not so many people that would agree, you know, if you got a room of cardiologists or cardiothoracic surgeons together that would agree. And then class 3 would be it's not indicated at all. Okay? Yep.
Someone that has decreased exercise tolerance or breath, when do you decide to do a stress after?
Right. Well, obviously, shortness of breath and decreased exercise capacity is a very common finding. And so, you know, is this cardiac disease? Is it deconditioning? Do they have pulmonary disease? That's not always easy to decide. But if you think that it's reasonable that it could be a cardiac etiology, that would be a reasonable reason to do a stress echo. However, you're supposed to do a standard treadmill first if they have a normal EKG. If they don't have if they have an abnormal EKG, that would be an indication to do a stress echo. But if they have a normal EKG, the recommendations are you just do a standard stress test.
So the first test is an EKG.
Pardon me?
So you're saying the first test you would do when you get that history.
Right. Now, but if you hear a murmur, that's a different story. Then, you know, then you would want an echo.